live now.
Light off करिए.
Yes. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Breastfeeding in Modern World, Challenges and Solutions. So it's my privilege to introduce the conveners of today's webinar, Dr. Divya Singhal ma'am. Ma'am is the National Coordinator of Breast and Puerperal Committee, FOXY, and immediate past President of DJF North Delhi. I welcome you, ma'am. And it's my honor to introduce Dr. Sonia Mandappa, ma'am. Ma'am is the Secretary of KCOG and Advisor Safe Motherhood Committee, Kasoga 23 to 25, and Advisor Breast Imaging Committee, Kasoga 23 to 25. I welcome you, ma'am, and I hand over the session to the conveners.
Thank you very much, Saiti, and warm welcome and good evening. In particular, a good morning to Dr. Cheryl, who's amongst us today. A warm welcome to each one of you joining us on this important webinar titled Breastfeeding in the Modern World, Challenges and Solutions. It's a privilege to bring together experts, practitioners, and passionate advocates of maternal and child health on this virtual platform, especially during a time when the conversation around breastfeeding needs renewed attention, support, and innovation. In today's fast-evolving world, with the changing lifestyles, digital distractions, workplace demands, and shifting family dynamics, this seems to be a very important topic of discussion. So this webinar aims not only to highlight the real-world challenges, but also to offer practical, evidence-based solutions. We will be hearing from renowned speaker and panelists who will bring with them a wealth of experience and insights. I thank all of you who have logged in today and who will be logging in the next few minutes for your presence, because today is a testament to your commitment to better maternal and healthcare outcomes. With this, I now request Dr. Charulata, who is the chairperson of Study on Female Breast Committee, FOXY, member of Breast Health Committee, FIGO, a very vibrant member who has hoisted flag of this particular committee from FOXY to FIGO. Over to you, madam.
Thank you so much, Sonia, for those kind words. And indeed, a pleasure to be here amongst such stalwarts, not only in India, but India and abroad. Dr. Hema, this entire webinar is the effect of your inputs and your passion towards commitment towards women's health. So thank you so much for taking all the steps to organize this fantastic SEFOG webinar on breastfeeding in the modern world, challenges and solutions. The theme for this year of the World Breastfeeding Week theme is prioritize breastfeeding, create a sustainable support system. The support system is going to involve not only the patient's or the woman's family, but also the entire society. And we as such important people of society, the obstetricians, who are probably the first point of contact for every woman, whether it is for pregnancy, whether it is for breastfeeding, whether it is for breast health or any other reproductive health. I think, as Dr. Divya was rightly mentioning, that we should not feel that this is entirely the job of the lactation consultant or the midwives, but we ourselves need to be trained. We need to know the problems that can occur and the possible solutions. So I think today's webinar about, the challenges in the modern world are so immense. And probably one of the most important one is the challenge for working women. All of us here are working women. We know how we struggled to make, time for our practice and for our family and of course also for breastfeeding. But I think the world of today is more ruthless than what it was, at least at my time. And I can see that the girls definitely face a lot of problems to continue their breastfeeding, although they really wish to do so. And we're going to try to find the answers through Dr. Sharon Maas's talk. We are so fortunate that that this is a SEFO, that is the South Asian Federation of Obstetrics and Gynecology workshop. We are very thankful to Dr. Sham Desai, who's the president of SAFOG currently, and Dr. Farhana Diwan, Secretary General of SAFOG, and of course to Seema Divakar ma'am, who is such an important part not only of SAFOG but also of FIGO, because of which this webinar has become a possibility. I would just like to say that this is my third year as the chairperson of the Breast and Puerperal Health Committee and the first year as the FIGO Breast Health Committee. As I'm finishing one and entering into another new role, I'm thankful to Dr. Hema Divakar for giving us this platform of SIFOG also. And I would really want her to highlight when she blesses this beautiful webinar as to her entire projects and her thought process for the field of breastfeeding and for the field of womanhood. With these words, I request Sahithi to kindly, play the prayer. Without the blessings of Saraswati, we are not going to move ahead. So over to you, Sahithi.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणि विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा।
Dr. Divya and Sonia, over to you all.
So, Dr. Charu, we'd like you to invite Dr. Sham Desai to say a few words and
Right.
bless the meeting.
Dr. Sham Desai, the current president of the South Asian Federation of Obstetrics and Gynac, and also the past president of FOXY in 2005, the past president of the Mumbai OBGYN Society, past president of the Indian Association of Gynec Endoscopists, vice chair ICOG, chairperson Maternal and Perinatal Health Committee of AOFOG 2009 to 2013, and a very renowned teacher, a very humble person, a very well-read person. We are very fortunate to have been able to conduct this webinar under the aegis of SAFOG. Thanks to Dr. Sham Desai. I think Sir is unable to join just now, and we would definitely request for his blessings as soon as he joins. Can we have the next CV, please?
So, Dr. Sonia, would you like to invite Dr. Farhana Diwan?
In Madam's absence, it gives me an immense pleasure and also welcome her. Probably she'll be joining in the next few minutes. She's a distinguished leader in the field of obs and gyns, a passionate advocate of women's health across South Asia, and her unwavering dedication across the borders of promoting evidence-based care has made a lasting impact in our fraternity. So it's our privilege and honor that if she joins us today, we will in fact interrupt in between and welcome her again. Thank you.
Thank you, Dr. Sonia. And now it's my privilege and honor to welcome the one and only Dr. Hema Divakar, who is Director, Well Woman Healthcare Committee, FIGO. She's Chairperson, Nutrition and Breastfeeding Committee of SAFOG. And she's also running her own organization, The Artist, which is Asian Research and Training Institute for Skill Transfer. She is running a Janani helpline. This is a helpline for women in distress, and we'd like Madam to tell us more about Janani and her vision. I love the positive energy of Madam, and I really feel very honored and privileged to introduce her. Over to you, Madam.
Thank you so much. Namaskar, everyone. And very, very, very special welcome to Sharon. And to put it in the context of what and how we began this webinar with, it was Ma Saraswati, the goddess of learning, who inspires us every day to learn, unlearn, relearn, all the way through. And there is no stopping the mind to grasp more. Similarly, the lighting of the lamp, which we always do, there's no use just gathering the knowledge for your own self. It needs to be disseminated to make this world a better and a brighter place. And therefore, one wick after another, one person into another keeps propagating what we have learned for making this world a better place. So that was the context. And we always believe that there has to be the grace of God and there has to be one Charu Bapai who has to agree to do any number of things that we ask her to do with a whole battalion of the fresh leads who are also in this program, Sonia and Divya, who are of immense support, and Nibha, Payal, Anita ji, and Taru and Uma, who are the distinguished faculty, besides Sharon Mas. So I just had the context to share about how this entire committee for nutrition and breastfeeding came about in the organization called CEFOG. It was in one of the UNICEF meetings that there was a call for action for OBGYNs, and FIGO endorsed that action, knowing fully well the statistics, some of which is fragmented and unrecorded even, that as many as 40% of the babies are not put to breast, maybe so many myths and misconceptions. They may think she's had a hard time in labor, let her rest for a while, or she's still on the IV fluids, maybe we'll start the feeding tomorrow, so on and so forth. The 6 months exclusive feeding also, not sensitized enough. Just 3 days ago, I was with Farhana Diwan, the Secretary General of the CEFOG region, who hosted a mammoth conference in Dhaka, Bangladesh. And because it was the first week of August, which happens to be the International Week for Breastfeeding Awareness, I had to speak on obesity, but it is also one of the issues which is complemented by the prolonged breastfeeding, and there are certain advantages of that. So I took the opportunity to tell our audience that, guys, at least two simple things, so doable, so feasible. It's really not it's a clarion call, but it is about such simple initiatives that we can do. So about 3 years ago, when this was pitched to the CEFOC president, then the new committee was constituted on breastfeeding and nutrition, which is a mandate of UNICEF as well as FIGO. And I was planted as the chairperson, and there has been no looking back, because simple things to do, but immense impact, as Sharon would bring it to your notice very soon. The breastfeeding facilitators course that we started, one of the lead master trainers, Payal Biswasu, is already on this program. Sheetal is a dietitian and nutritionist who ably supports Payal for running these courses of breastfeeding facilitators in all the private settings and also the public health sector, where the staff who are already in the system are specially trained for a lot of nuances and myths and misconceptions that they may themselves have, so that they can give the right message to the new mothers and their families. So every year, FIGO produces a position statement and the social media channel, but one person, one organization, enough is not enough. So each one of us, we urge you to spread the simple message and also get your staff enrolled into simple courses like these. It's just 1 hour, 3 modules, so 3 hours they're done, and they have to appear for an online exam at the HSSC or the Health Sector Skill Council, and they're certified breastfeeding facilitators. And the feedback that we hear from the head of institutes and the OBGYNs of those settings where the staff is empowered to double up as breastfeeding facilitators has been very, very heartening, satisfying, and very joyous moment for us, because they have recognized that it has made such a big difference and a big impact, inclusive of the better mental health of the new mothers who are so shrouded with anxiety. So this is our 500th breastfeeding facilitators, which is a big milestone in itself, but the target is a minimum of 10,000 breastfeeding facilitators to be empowered in a program called SEE, Skill, Empower, and Employ, because these breastfeeding facilitators within the medium and small size settings with the certificate are getting a small incentive for the extra work that they do. So it's linked to their livelihood as well. So
Did we lose Madam?
Yeah, I think
Network is
some
probably-
network issue. We'll just check.
Yes.
Yeah, maybe she'll join in a minute. I'll just give her a call and see. Ah,
these interruptions, such as unable to breastfeed at the right moment, can happen in anybody's life. Take you and catch you unawares. So I think the deliberations in this crucial meeting would be very, very impactful, because once the delegates understand that it's so doable, so feasible, and it's their responsibility to take this movement further. So one last time, wishing everybody the best of the advice to each and every new mother and their families for simple things around the breastfeeding, which gift a disease-free and a good health to the future generations. With that, I apologize for the small interruption, and we wish you the very best in carrying not only this program, but also many, many more to go. Thank you again. Namaskar.
Thank you so much, ma'am.
can I just interrupt? I think Dr. Hema Divakar deserves a big round of applause for her program, which is, it is such a unique thought process of training the paramedics and, giving them a better livelihood. So they gain, and in the bargain, our new mothers gain. So, madam, we are really, really blessed to be a part of the Janani program, and we are so fortunate that you are leading us in this. You have completed 500, which is a massive number, and we are your helping hands for the remaining 10,000 that you wish to
I
reach.
have asked Aru again to continue the legacy forward, so the ball is now in her court.
Thank you so much, madam. It is a big responsibility on my shoulders, but with you as a guiding force, I'm sure it's not going to be as difficult as I think it is. And the second thing that we would like to mention is about the Breast Health Committee of FIGO, which is doing amazing work once again under Dr. Hema's leadership. Sharon and myself are attending meetings, and sometimes I miss out on the in between Zoom meetings because of probably some work pressures. But we would like to tell everybody out here that Run for Fun is probably one of the first things that has occurred, the first new thing that has occurred in this time's FIGO in Cape Town, where we are going to run for breast health. It is a breast health committee initiative. And once again, we are blessed by none other than Bloom IVF, looked after by Dr. Rishikesh Pai and Dr. Nandita Palshetkar, who have agreed to sponsor t-shirts and caps for this particular run. And I would really urge each and every one of you who's going to be there in Cape Town to definitely participate in the run. I will definitely be forwarding the details about the date and the time, but I think you need to register for the run also. So, encouraging each and everybody to participate in the run for breast health and for fitness. So yeah, that has been a massive introduction, I think, to so many things. But yeah, so many things occurring at so many platforms and in so many forums that we had to get them across to all of you. So over to you, Dr. Divya and Dr. Sonia.
So, Dr. Charu, we would like you to introduce our international speaker, Dr. Sharon Moss, please.
It is indeed my proud privilege to speak about Sharon Mas. She and me probably first connected 6 months back, which when it was our first FIGO meeting of the Breast Health Committee. And she is so vocal and she's so passionate about the topic of breastfeeding and breast health that, as Dr. Hema said, the first name that came to our mind was of Sharon Mas for this particular webinar. So Sharon is an MD FACOG. She has got a number of passions, it looks like, and she has held so many positions that I think I just need to enumerate them. She's received her medical degree from the Jefferson Medical College, UG degree from the Cornell University. Currently, she's affiliated with Morristown Medical Center. She's the vice chair of the OBGYN department since July 2023 until now. And she's a part of the Lifeline Medical Associates and Morristown OBGYN Associates. Her professional affiliations are as follows. She's the FIGO appointee, as I just mentioned, of the Breast Health Committee. Has been the session chair at the 2025 FIGO World Congress in Cape Town, South Africa. She's the co-author of the position paper on breast cancer screening and diagnosis around the globe, practices, barriers and solutions. Yes, and we are very proud that our committee is coming out with this paper too. She's a part of the Association of Professors of Gynecology and Obstetrics, APGO, since 2024 until now. She's a member of the Academy of Breastfeeding Medicine, and that is exactly why she's here with us today, mainly so. She's a part of the American College of OBGYN, District 3 representative to National Board of Directors 2025 to 2028, District 3 representative to Council of District Chairs 2025 to 2028, District 3 chair, District 3 vice chair and chair elect, and she's the chair of the National Breastfeeding Expert Group since 2021 until present. Sharon, we are really very fortunate to have you here. She has won a number of awards and recognition as the American College of Obstetricians and Gynecologists, the National Medical Student Recruitment Award, and the Sydney Kimmel Medical College Dean's Award for Excellence in Education and Award for Outstanding Adjunct Teaching in May 2025. Wow, that is a very fantastic CV that you have, Sharon, and we are so proud and privileged to have you here to talk upon a very, very important topic. And over to you, Sharon.
Oh, thank you so much, and it truly is my honor. Good afternoon to all of you. It's 7:30 in the morning here, so forgive me if I'm just waking up and drinking my coffee as we go. But I'm just so privileged to be among the esteemed, and I can only hope in my life to achieve the same kinds of things that Dr. Hema has done. And I think you're an example. All of you are examples of the impact that one person can have on many patients, on a region, on a country, on a society. And I think if we each play our part, then we can make a big difference as a whole. Thank you for that introduction, but I think the best way to boil everything down is that I am, a private practicing OBGYN who practices at a large community hospital where I have the privilege of running the medical student program and working with residents and educators to really promote messages that are important to me. And one of my areas of interest is breast health, both in terms of breastfeeding and in terms of breast cancer. So that's the impetus behind my joining the International Breast Health Committee. So I'm going to try to take a few minutes. I will say that this is put together as more of a formal talk, but I really welcome your input. And I tried to give some comparisons between some of the things that we see in the United States and some of the things that I was able to explore online with regard to working women and breastfeeding. But would love any input or thoughts that you have as we go. And I very much welcome questions at the end. So I'm going to do the hard part of my job, which is try to share my screen because I am not technologically a good person. Here, let's see if we can share here. And give me one moment to just go into the proper mode. Okay. You can see my screen okay there? Okay, perfect. Okay, so my task today was really to look at breastfeeding in the workplace and what some of the policies and challenges are. And I look at it with an eye to what can we as individuals do to impact the lives of our patients while we look at it from a societal perspective. As Sharu mentioned, this is World Breastfeeding Week, and we are looking to prioritize breastfeeding by creating sustainable support systems. And each and every one of us is part of that support system. And it's only when we work together that we can truly make an impact. So today I wanted to look at the importance of exclusive breastfeeding. I just have to modify my screen here a little bit. So hang on one moment. Explore some of the barriers to optimal breastfeeding support, particularly in the workplace, and to highlight some of the gaps and recommendations for both workplace support and public policy for the working women who breastfeed in both South Asia and the United States. So I think most of us on this call are probably familiar with the WHO and UNICEF Baby-Friendly Hospital Initiative guidelines for breastfeeding. But just to review them today, we do know that they recommend that breastfeeding be initiated within the first hour after birth, that it be continued exclusively for the first 6 months of life, and ongoing with safe and adequate complementary foods up to 2 years and beyond. And your organization has publicly aligned with the WHO, really emphasizing the importance of supporting mothers in achieving their breastfeeding goals by looking at some of the factors that hinder that successful breastfeeding, such as access to information, support from all providers, both medical and support providers, and of course, the workplace challenges that each and every one of us probably also experiences. I'm sure for many of you, just getting to this webinar at the end of a long day is a challenge. ACOG is the United States National Organization, American College of Obstetricians and Gynecologists, and we have similar guidelines that all mothers and infants, with rare exceptions, should breastfeed exclusively for 6 months, and have recently updated the recommendations to align with both the American Academy of Pediatrics and WHO to support continued breastfeeding for up to 2 years and beyond. And just to clarify, when we're talking about exclusive breast milk feeding, the definition of that is important because people have different perceptions about what breastfeeding is. But for today, we're going to use the definition of exclusive breast milk feeding as receiving only breast milk and no other liquids or solids except for drops or syrups that contain vitamins, minerals, and medicines. And I think the important part of understanding breastfeeding in a working woman is understanding why exclusive or almost exclusive breastfeeding matters. And there can be both health benefits to the infant and mother, but also economic benefits to our societies with reduced healthcare costs and retention of our workers in the healthcare environment. So touching briefly, and I won't belabor this because this is not the point of this talk, we know that there are significant health benefits both to mothers who breastfeed with reduction in lifetime risk of breast cancer, ovarian cancer, type 2 diabetes, high blood pressure, and I should probably have it on this slide, as Hema mentioned earlier, maternal obesity, but also babies, benefits to babies, knowing that babies who breastfeed have a lower risk of a number of diseases, including asthma, obesity, type 1 diabetes, severe lower respiratory disease, otitis media, SIDS, and gastrointestinal infections. And in fact, South Asia does have one of the highest neonatal and infant mortality rates globally. So when we look at some of those diseases specifically, exclusive breastfeeding for the first 6 months can reduce some of those risks quite dramatically, with diarrhea risk reduced by up to 50%, pneumonia, respiratory infection risk up to 23%, and of course, having both the reduced hospitalizations, antibiotic prescriptions will reduce the pressure on what can be a challenging healthcare infrastructure. Now, when we turn to the economic benefits, it's very interesting. And, I sort of laughed as I was putting this together because the study that is quoted most commonly across the United States is this first study from Melissa Bartik. And if you look at the date, you say, how is it in 2025 that we're quoting a study from 2010? But she really was the first person to quantify the impact of suboptimal breastfeeding costs in the United States. And as of 2010, I'm sure it's far higher today, noted that over $3 billion annually was attributable to suboptimal breastfeeding as a result of direct medical costs for treating diseases preventable by breastfeeding. And when we look across South Asia and some of the estimates that are out there from Alive and Thrive and WABA and UNICEF, you can see that there are, reductions in the billions that represent a significant portion of gross domestic product in many of our countries. So there can be a significant impact by making the small differences that support exclusive breastfeeding. And we're going to touch on this briefly in a short case study, but many women work in the informal economy and don't have access to some of the workplace regulations that we have. But the International Labor Organization estimates, that every dollar invested in maternity protection yields a 3-time return through that improvement in maternal child health and work productivity. So while it costs money to set up some of the infrastructure, it saves money in the long run if we can invest not only in the education and support, but the laws and infrastructure in our countries to support our working women who want to breastfeed. So how are we doing? And, I briefly started by looking at some of the US data, and we quantify things through some initiatives called Healthy People 2020. Most of the data is still, 5 or 7 years behind, but our new objectives are for Healthy People 2030. And it really is the guideline for national objectives to improve health and well-being over the decade. And we have quite a number of initiatives that are related to breastfeeding. And, this is a busy slide, so I don't want to belabor it. But what I would like to point out is a couple things. And I don't know if my pointer is working, but if you look at the second to bottom line here, one of the places that we're really falling down in the United States is the proportion of breastfed newborns who receive formula in the first 2 days of life, really reflecting supplementation in the hospital alone. And I think Dr. Hema touched on this. We want to empathize with our patients who may be tired, and we want to, support them in their recoveries from what could be a difficult labor or an unexpected C-section. But there's significant impact to just that supplementation in the first 2 days of life. And if we can promote exclusive breastfeeding in the hospital for those mothers that want to breastfeed, we make a big difference. So here in the United States, our most recent data also looked at breastfeeding through 6 months of age. And you can see that while our target is having 42% of our patients be breastfeeding at 6 months of age, the most recent data showed that only a quarter of them were, despite intentions of the mother. And I think for me, that's the most important thing. It's not patients that we're trying to talk into breastfeeding. These are mothers who want to breastfeed, but through a variety of barriers, one of which is return to work, are unable to meet their goals. And in fact, what we found is that 60% of mothers stop breastfeeding earlier than they intended to do so. And it can be a variety of factors. And again, this is not our topic today, so I'm not going to belabor these, but concerns, cultural norms, unsupportive hospital practices. But one of the biggest factors is our unsupportive work policies and lack of parental leave. And if we can start to make inroads into these, we might be able to help the 60% of mothers that would like to breastfeed longer than they're able to. So let's just look very briefly at a case study. I selected Meena, who is a 28-year-old mother of two living in an peri-urban area in India, working as a garment factory worker and earning minimum wage. And she has a 3-month-old baby. She did receive education from her ASHA worker and had intended to exclusively breastfeed for 6 months. And indeed did breastfeed her first child for 7 months and really wanted to do the same or more for her son now. However, she was only granted a few weeks of unpaid leave, even though there are some laws that we're going to touch on that mandate longer leave for certain professionals. And she was actually not, as a contract worker, she was not officially on the company payroll, so the maternity benefit coverage did not apply to her. She was unable to not work and to not be making an income, so she did return to work after 6 weeks. She had to leave her infant in the care of her mother-in-law, who was an hour away and not easy access. She had to take a bus to drop her child off. And unfortunately, her workplace did not have a place for her child to be with her, nor was there provision for her to stop and express her own breast milk while she was working. And even if she had been able to find a private place to do so, her workplace did not have refrigeration available, and her express milk would not have been able to be safely stored or transported. And while, this was somebody who was really motivated to breastfeed, she began supplementing with supplemental intake at 7 weeks postpartum. And by 3 months had stopped exclusively breastfeeding and was, feeling sad and frustrated by that, lacking the support to continue. So when I looked at some of the policies, there are quite a number of really wonderful national policies across South Asia. And I, unfortunately, because of time, can't really delve into the details of all of them. But I just wanted to highlight the fact that there are maternity leave benefits, childcare benefits, nursing break benefits, and in fact, conditional cash transfer. I'm not sure, I'm sure many of you are familiar with these, but that was interesting to me because we do not have that in the United States. So, promoting prenatal care and exclusive breastfeeding to offset wage loss for low-income mothers. And, that was something interesting to me. The challenge, I think, is that Meena is reflective of 90% of our working women. And I wrote in South Asia here, but I think that the same pertains to the United States, where many women are employed in the informal sector without access to the legal provisions that many of us may be privy to. And return to work is really one of the causes of early weaning. So, what we do as OBGYN professionals to support the working women that we are caring for really does make a difference. I'm going to breeze through these next couple slides just because of time, but there are similar provisions across many of the countries in South Asia with maternity leave benefits, prohibitions of termination of work, in Nepal, again, maternity and paternity leave benefits, and provision of either shared childcare or daycare facilities for employers that have greater than, and I loved this, greater than 50 female employees. So a lot of our provisions just relate to the number of employees, not the female employees. So that was an interesting difference for me. Similarly, in Pakistan, having maternity and paternity leave provisions and extending some of those labor protections for the home-based workers in Pakistan, and that is something that seemed like it was unique in South Asia. Similarly, in Sri Lanka and several other countries. So when we look, I think the thing that stood out to me was the sort of depth and breadth of the provisions that exist from a legal perspective. So we can see that there are paid maternity leaves, paid paternity leaves, childcare provisions, break provisions. But the problem is that they're not universal and they're not guaranteed, and they don't necessarily apply to some of the millions of workers who are in our informal sector. Just so that you're aware of where I'm coming from, in the United States at this time, there is no national paid maternity leave policy. So we do have, through the Obama Affordable Care Act, some mandates for break time and space to pump. We actually have provisions for free access to pumps for women, which is fantastic. So even women who are in my practice, which is a little bit more patients who could afford their pumps, they are able to get pumps free of charge and take them with them to work. And, really the only benefit that most women in the United States have is the Family Medical and Leave Act, which is 12 weeks of unpaid leave. And people don't universally take that, again, because for many women, 12 weeks unpaid is not something that's feasible for their families. These are just some of the US national provisions. And again, this is beyond the scope of this, but we have a lot of legislation that is introduced. They have beautiful names like Fairness for Breastfeeding and Friendly Airports and the BABES Act and the Pump Act and, all kinds of beautiful acronyms. But the reality is that when they're put into place, a number of women are unable to really access, be aware of, or really reap the benefits of some of these national provisions that have been introduced. And I think it's just, astounding that the United States really remains one of the few countries without any federal mandated paid family leave. So what can we as individuals do? And I alluded to it in some of the preview, but I think each and every one of us as an obstetrician can impact our patients directly. So I always share this slide anytime I give a talk about breastfeeding to obstetrician gynecologists. I like to share this study, which is just many years old. I think it's 20 or 25 years old, but DiGirolamo showed that when women were asked about their perceived what they perceived their obstetrician to think about breastfeeding, the results are astounding. So for women who thought that their obstetrician or their physician favored breastfeeding, 70% of them were breastfeeding at 6 weeks. For those who thought that their physician had no preference, in other words, it wasn't brought up at any prenatal visit, there wasn't a discussion about the importance of breastfeeding, 54% of those patients were breastfeeding at 6 weeks. And for those women who thought their physician actually favored formula, it was recommended, there was a reason that they were told to supplement, only 9% were breastfeeding at 6 weeks. And what this says to me, even though it's an old study, is that something like a simple conversation early in prenatal care to discuss the importance of breastfeeding and to start to work with the woman to see what can be done to support her breastfeeding goals can make an enormous difference in not only her life, but in her baby's life, because women who are breastfeeding at 6 weeks have longer breastfeeding at 6 months and at 1 year. So, we as individuals have a number of roles. We're the clinician where we want to educate and counsel our patients. But I think, the point that I'd like to get across is that we really need to become advocates for our patients and take it like Hema and Sharu have done, and all of you have done, to push for systemic protections and changes in the workplace on behalf of our individual patients. Linking patients to support networks, our lactation specialists, our nurses, our midwives, our private sector support services, our pump services, and then, like you are doing through your beautiful program, training peers so that we can influence the public health messaging. Before I finish up, I do want to just touch on a couple resources that are out there that you may or may not be aware of, but this is the Breastfeeding Handbook for Physicians, which was a joint endeavor now in its third edition between the American College of OBGYN and the American Academy of Pediatrics. And it does touch on some workplace support, but a lot of other things that the physician can do specifically for the patient, and is a great educational tool for your trainees. If you have residents or medical students who are interested in breastfeeding medicine, it is a wonderful resource and is available for purchase, I believe. I'm not sure that it's accessible online. Most of our individual guidelines are available free of charge. We talked about the Academy of Breastfeeding Medicine, and not only do they have a scientific journal where data and research about breastfeeding is presented, they also put together a number of fantastic protocols that are accessible online, can be downloaded and modified to your individual hospitals, and are available translated into a number of languages as well. And then, these are just some of the US websites, but for those of you who are not familiar with things like LactMed, this is a website where pretty much any medication can be explored with the guidelines, the data, and a very sort of clearly understood recommendation about whether a medication is safe to use in a breastfeeding mother. And so these are just some places where we can refer patients or providers to gain more information about breastfeeding. But like I say, if you're not familiar with LactMed, it is a resource that I use almost every day for mothers who are worried about, or even other providers who are worried about, use of medications in breastfeeding. So while I had to dash through a lot of information, I would like to say my overall feeling is that all patients who wish to breastfeed should have the optimal support to do so. And one key element of that support is workplace reform, so that we can make sure that across the globe, the breastfeeding is supported and is really intersecting with gender rights and with overall health. And that as obstetrician gynecologists, we can be advocates for our patients at both an individual and at a societal level. So this is my favorite quote. I think my being here today across the globe with all of you is testament to the fact that if you wish to go fast, go alone. But if you wish to go far, go together. And I will take what I learned from all of you today and bring it back to hopefully impact the lives of our breastfeeding women in the United States. And I hope that each of you can take a little something out of this talk, look into your national guidelines, and see what you can do to support the working women in your realm. So with that, I will certainly address any questions, but also turn this back over to your moderators, and I look forward to hearing what the rest of your speakers have to say. So thank you.
Big round of applause to you, Sharon. That was so well put forward. And I think the immense efforts that you took to go through the policies in South Asia, and I think probably all the policies that you found in regarding India too. It is very creditable that you took so much pains and efforts to put this talk together, especially for your presentation in the SAFOG. I think. So many highlights of your talk. The meaning of exclusive breastfeeding. I think that only breast milk being fed. this is very important essentially because in India, we have so many religious beliefs. Whenever the baby is born, the first thing that we have to say is that please don't give honey. Or there are some communities who will give an ancient gold ring which is running down in their families, which has to be touched to the to the lips or the tongue of the baby as the first thing, and so many more things. There are some communities which believe in feeding the baby with donkey's milk. So I think religious constraints is something very important that we need to think about. Of course, the various benefits to the mother and child go so way beyond that we could have an entire webinar on it, and you rightly pointed it out. And 60% stopping breastfeeding because of lack of parental leave. Now, Sharon, I'm going to be a little upset with the United States because I'm going to have a grandson in 2 months' time, and my daughter-in-law, who is doing her pulmonary and critical care fellowship in the US, is going to be at home for barely 6 weeks. And now, when I go over to her, and what am I going to tell her? How is she going to breastfeed? She will be working in the hospital. I will be looking after her baby half the time and maybe her mother the rest of the time. And it is, you realize that your children have moved from India to the United States thinking it's a bigger opportunity that they're getting. And we are lacking in some basic stuff.
Yeah.
It is
No, I
disheartening
think
and
that's
disappointing.
it's a great point. And, I mean, obviously I didn't touch quite as much on the services available to resourced patients, right? So, I mean, your daughter has some resources. I will say many of the healthcare facilities do have things like pump rooms, storage facilities, breastfeeding provisions, but many of our residents go back to work after 4 weeks because they are only allowed to take a certain amount of time out of their residency across the 4 years of residency. So, while we do support them in pumping, if they are in a gynecologic oncology surgery, they can't exactly walk out, every 2 hours to pump the breasts, and it's a huge challenge. But I think we have to learn from each other and see what's working in different regions of the world, and try to bring those best practices back. We do that on a local level at our hospital, and we have break rooms across the hospital, but it's been hard to support that, on a national level.
Yeah. I think Hema ma'am is going to agree that she lives in Bangalore, and Bangalore is one of the biggest IT hubs in India. And the kind of paid maternity leave that those girls get is mind blowing. It is so beautiful because they can be home for close to 6 months. And even after that, they have the opportunity of working from home. So, of course, we as medical professionals don't have that privilege of being able to work from home. But I think the IT professionals in India are doing extremely well. They are managing their work-life balance much, much better than some other professionals. And I really appreciate, Sharon, you talking about that the mill worker, because it is so true that her house depends on her income and her wages. And if she doesn't go back to work, they may probably end up starving half of the week. I don't know, maybe people like Hema, people in the position of Hema may be able to, have some kind of a movement started, or I think we could really do with a lot of inputs from everybody.
Yeah, I think thank you, Sharon, for that wonderful morning wake up call from your end to all of us. Okay. And as Charu said, and as you also commented, each one, whatever, it becomes a movement, Charu, when each one synergizes and escalates the noise level together. As her last slide said, together we can really move far. So, one thing at a time, we are slowly and steadily, I think we are getting where we want to get at, because some of the core team within our own parent organization, Foxy, as well, is
Yes.
very, very strong in their advocacy and to push the needle forward for the policies as well. Two or three small points I just wanted to place on records. It's not only the workplaces, but also the public places like the airports, who need, privacy for the breastfeeding because there are long hours with check-in, waiting, delayed
Yes.
flights, etc. So one of our own members and past presidents of Foxy, Dr. Gupte, he has a foundation where, it supports the execution and construction of the breastfeeding private places within several airports. So that is also, it's just out of the box thinking, and it is the need which is fulfilled by, as you said, one individual's thought process and generosity to contribute. The breast milk banks, I think Payal is a testimony to the fact that how she has moved the needle ahead for that with organizations like Rotary, etc. So that's also slowly, steadily picking up. So there are such options also. And the last thing is, this is a tech-driven world. So lot many app developers who have had the most awful time in their life as new mothers are very worked up about the support to new mothers. So they're coming up with several such apps for new mothers, and they need the counselors and the breastfeeding facilitators at the back end to support the calls that they get, more than several hundreds per day. So I think all the dots are being connected for a larger good, and the more we discuss about this, newer thoughts that we get, and always, however slowly, but it is a forward movement. And we thank everybody, all the champions right across the globe, for joining hands for the best we could do. Thank you so much again.
Dr. Charu, any more questions?
What about all of us? Any of us who want to make any comments, have any inputs?
Dr. Sharon Maas, I just wanted to make a comment that in a place like India, where we have a lot of women labor working, and they won't have the facility of a refrigerator to store their milk as working women. So they could probably use these frozen bags or ice bags and collect the milk in these particular bags, which can be put along with the ice bag packs. So maybe that would help.
Yeah,
These
and that's part of some of the pumps that are provided in the United States come with little freezer packs and a freezer unit, so it can stay for up to 12 hours and then be put back into the patient's individual refrigerator or freezer. So yes, small solutions like that can make a big difference on an individual level.
Right.
Thank you. Thank you. So
Wonderful presentation, Charu. Can I make a point? Yeah.
Yes, please.
Dr. Anita here. So wonderful presentation, Dr. Sharon. It was so important. You have discussed all the important policies that are going around in world. As far as India is concerned, we promote a lot of breastfeeding as a national policy. Baby friendly hospital initiative is there. And as far as nursing mothers are concerned, they are given nursing breaks also. They can go and feed their baby 15 or 20 or 30 minutes break. The time is allowed for coming and going also if they are, residing around their workplaces. Maternity benefit here is for 6 months. And fortunately, they can add on to their other kind of leaves with these maternity leaves. So that way India is quite determined to promote breastfeeding. We are almost promoting breastfeeding for at least 1 year, exclusive for 6 months, and then of course supplementary feed is given. And now mothers are being rather encouraged to feed even for 2 years, whoever can feed. So that way, a lot of benefits are there, creches are there, feeding corners are there, feeding rooms are there. Even our airports, railway stations, all these things, because of this initiative of government, we are very pro breastfeeding, ma'am. And I think we all should move forward in this direction. It was a wonderful presentation. Thank you. Thank you for letting us know what the world is doing about it. Thank you so much, ma'am.
And thank you for elucidating that. I think, many of those things exist. I think the challenge is both in the enforcement, making sure that people are aware of those provisions, making sure that the employers enforce those provisions. And, really, I mean, I know as a breastfeeding mother, I had certain rights to breastfeed, but sometimes I just couldn't physically complete my day and stop to pump at the same time, right? So if I was in a surgery or I was with a patient who was a little bit more complicated and it, blended into my break, even though I had the right to do so, I actually stopped breastfeeding sooner than I wanted to because I really lost my supply, at about 6 to 8 months with my second child. So she happens to be a second-year medical student now and turned out okay despite missing out on a few months of breastfeeding. But, my own goals were curtailed by my professional goals. And, those were in conflict. And I think that that's one of the challenges for many professional women is how do we maintain our accomplishments and our status and, achieve what we need for ourselves and our patients while still supporting our families. So.
And as Hema ma'am has very kindly highlighted, we are very strict about even milk substitutes. We can't advertise at any public place. It is not promoted in hospitals. So that way, I think we are doing quite a lot of effort on our part for promoting breastfeeding, exclusive breastfeeding rather. Thank you so much. Thank you so much.
So, thank you, Dr. Sharon Maas. This was
Payal
really
wants to
nice
say
in the way.
something.
Yeah, and the way, you touched upon the emotional aspect, the ambitions of the professional woman versus her ideas for breastfeeding. So over to you, Dr. Charulata. Yes.
I think Dr. Payal wishes to say something.
We can't hear you,
Unmute
Payal.
yourself.
No, your
You're
audio is
audible.
not on. Mhm.
Dr. Payal, unmute.
Now, you unmute yourself, Dr. Payal, now? Yes.
No, even then,
No.
she was unmuted before
You
also.
just check the mic
Yeah.
once.
Maybe you have to leave and come back again, Payal. Yeah, we can probably reserve Payal's comments for later.
Fair enough.
I think she's logged into the phone also now.
Yeah, so
You log out from your system now. You logged in your phone. You log out from the system so it doesn't echo. No.
Yeah, I
So
think
by that time, I can just mention about the awareness and the trend about breastfeeding that has increased in our next generation, the newer one. They are really very emphasizing about the immediate breastfeeding and to be continued even they are working, how to do the breastfeeding while doing their job. I've seen my own daughter. She was resident at AIMS Delhi. How concerned she was right from the day one. It should be totally exclusive breastfeeding and how to be stored, how to be fridged and everything. And I know lots of doctors in her circle that they are really going for exclusive breastfeeding. In fact, they are being the whole day working mother. So sometimes they bring their kid to the hospital. Sometimes they go to their room to feed their kids, and it has been, I find it's really at the time as with time it's the trend is being changed for exclusive breastfeeding in our society also, as Dr. Sharan has said. So thank you for that.
thank you.
So thank you very much, Dr. Sharon Maas, once again, and all the people who have interacted. Thank you, madam. Over to Dr. Sonia Mandappa to introduce the panel and the model.
Thanking Madam Dr. Sharon for strengthening the support of breastfeeding in this modern age. We also would love you to hear our esteemed panelist with a very good moderator and expert. Moving ahead for a most relevant and insightful panel discussion, for which I call upon panelist, our own convener of today's webinar, Beauty with Brain, Dr. Divya Singhal, who's the National Coordinator of Breast Committee FOXY, and she's contributed to GCPRS on breastfeeding FOXY. Madam, we look forward to hear you and more discussions. We have our next panel, Dr. Taru Chaya, who is Consultant and Director of Bansal Hospital, Jaipur, and West Zone Coordinator, Breast Committee, FOXY. Welcome, Madam. We have Dr. Anita, who is probably on virtual platform every day, sharing her expertise as a senior consultant and heading the department, Delhi. And Madam, we look forward for your expert comments and sharing your experience. We've been hearing you all through the week, and here once again, you're in this virtual platform. Thanks and welcome you, ma'am. And we have Dr. Niba Mohan, a consultant from Reno Maternity Center, Patna. Madam is a treasurer and Patna Obs and Gynec Society. Now, Madam, every Foxian knows who Dr. Niba is. And we also look forward for your valuable inputs and discussions today. We welcome you, ma'am.
Thank you.
We have Dr. Pradnya, and Pradnya is a member and the managing committee FOXY. With a teaching experience and academic excellence, she will add on more take-home messages is what we expect. We welcome you, Dr. Pradnya. And I think, Dr. Payal, are you audible now?
Yes, am I audible?
Yes, you're not visible, but we are audible. I think you've logged in from your telephone.
Yes. So I'm visible from laptop and audible from phone.
Oh, that's great. I think that makes you bag a lot of awards, and I congratulate you. You've recently bagged another award. I think that's the Rotary Governor Special Recognition Award for the special recognition. And this is a very special topic which is created for a special situation. And the moderator being a very, very special person, and she is none other than Dr. Charulata. Madam, with your guidance, anyway, now you've made us understand that you're making everybody run for breast health. And now the panelists will also be running for giving us the tips and the special situations, for which we have our expert for today, Dr. Uma, who is a professor and HOD at GMC Baramati. And Madam is also a president-elect from Pune OBGYN Society. Madam, we look forward you for valuable perspectives and evidence-based insights after the discussion. With this, we look forward to listen to all your inputs, suggestions, and take-home messages. Over to you, Dr. Charulata.
Thank you so much, Sonia. I think we're really blessed to have a fantastic, array of panelists today. I would like to mention that is my screen visible?
Yes.
Yes, madam. Slideshow, please.
I'll just do the needful. So I would just like to mention that each and every one is extremely passionate about the field of breastfeeding. Each of them is has worked very hard in this field, and our expert, Dr. Uma Wankhede, she's also a IBCLC certified lactation consultant, along with being the head of the department of the Baramati Medical College. So who better could we have today than her as an expert for our breastfeeding in special situations? Divya, Taru, Anita, Nibha, all are working very hard in the breast committee. I would like to make a special mention about Dr. Pradnya. I think she too is an IBCLC, graduate in the field of breastfeeding, and she does a lot of work for our Foxy Journal. And Dr. Payal, I came to know, is a lactation consultant, mainly working at Dr. Divakar Hospital. So I'm sure she too has a very wide experience in this particular field. Breast milk, often referred to as liquid gold, is nature's remarkable gift to newborns. It goes beyond mere nourishment, fostering a profound bond between mother and child and laying the foundation for a lifetime of health and well being. It is the single most cost effective intervention for reducing morbidity and mortality in children. However, there could be situations where to breastfeed or not is the question. Benefits of breastfeeding have been enumerated time and again. Sharon has also touched upon them. And I think that, we are all extremely aware about the benefits, and that is exactly the reason why we are here today for today's webinar. And so we're going to talk about some special situations as far as breastfeeding concerns are there. Of course, every mother and child unit is a very special unit, but there could be some situations regarding mother's health and infant health, like infections, altered metabolic functions, cancers, post C section, critically ill mothers, breast health issues, mothers with addiction, working mothers, which we had a beautiful talk on from Sharon, and of course, infant problems like twin pregnancies, preterms, cleft lip, cleft palate, lactose intolerant, tongue ties, small for gestational age, and so many more. But today we're going to just touch upon a few of these topics and discuss them in some detail so that we can give a clear take home message. We'll be talking about mothers with infections, some kinds of cancers, post C-section, where because the incidence of C-section is rising globally, breast health issues, twins, cleft lip and palate children, and of course, we'll touch upon working mothers once again, because that is, one of the most important topics for today. So here we have a 21-year-old full-term primary. She's referred from a primary healthcare center. Sharon, just for your reference, India is such a big country, and there are such tiny villages all across that you have small primary healthcare centers, which look after the health of people. And most of the, what do you say, low risk women do tend to deliver in the primary healthcare centers also. So now this woman has come from a primary healthcare center with cough and blood and sputum since 15 days. She's 39 weeks pregnant, and she weighs just about 45 kilograms, and she's the wife of a mill worker. She delivers a male baby 2 kg before initiating any form of treatment. All the investigations are pointing towards pulmonary tuberculosis and is diagnosed with a sputum positive pulmonary TB on day 3. Now, of course, she's coughing out a bit of blood, and you're just starting her treatment, and here she has a newborn baby who's 2 kg. And How will we proceed? I mean, it is our duty to guide her regarding breastfeeding. So, Pratnya, would you want to take up this question?
Yes, ma'am. At the outset, I would like to thank you for involving me in this wonderful program with SEFA. And taking this question, I would like to say that it is very important to understand that breast milk itself does not pass tuberculosis. So, tuberculosis, even in tuberculosis, it is recommended that breastfeeding continues. Now, there are only certain conditions in which breastfeeding has to be stopped in tuberculosis, which includes untreated tuberculosis. So, TB is made non-contagious within 2 weeks of AKT. So, if she's taken 2 weeks of AKT, if she doesn't have MDR TB, or it is a resistant form, or it is untreated, then only you should stop breastfeeding. So even though all the things are pointed out, she can
Now, Pradnya, so this girl is untreated.
yeah.
You just have diagnosed her. She's not on any form of medications. And, how will we proceed for this particular lady? Would you advise a little bit of separation? Will you advise mask? Will you advise express breast milk? What will you advise for her?
Mask and general sanitation is definitely, as this is untreated coughs, then
Yes,
definitely, but still she can express and it can be fed. Because,
I
and baby also requires INH prophylaxis.
well said, well said.
So with all this, it is absolutely safe to give the breast milk as she is untreated. It has not yet been initiated. We can add the iron. We can start her on the treatment. And nowadays, with the newer tests, we get the turnaround time of the investigations is very fast. So you can get even the sensitivity reports very fast, and she can be put on a fixed dose combination of the AKT drugs, and she can express and it can be fed, unless only if it is proven it is multi-drug resistant, then
Right.
definitely you won't be giving. But
Absolutely.
point of time, she can wear a mask. Baby can be separated for a while till she is on treatment.
Right.
After 3 weeks are over and she's non-contagious, she can even go for direct breastfeeding.
Wonderful. Umar, do you want to add anything in this?
No, absolutely correct what she said, that for 2 weeks we'll separate the baby, express the milk, and we'll start the baby on the INH and maybe delay the BCG till the INH is given. Instead of giving at birth, you may give little later.
Charu, there is one more thing into this kind of case. She was diagnosed on third day, day 3 of postnatal
Yeah.
phase. So even in we are facing this challenge in public sector hospitals. Yeah, even if we are having suspicion of tuberculosis, like she was coughing and she was having productive cough. So in such patients, till we get the investigations report, we ask these mothers to observe those hygiene as Pradnya was talking about, and to wear mask. That is very, very one thing which is very important. Wearing mask and hygiene. Respiratory hygiene is very important because as such newborn has less immunity to tuberculosis. There is some, if the mother was immunized or being treated during pregnancy, then she can give, as Pradanya already highlighted. But in such cases, even if suspicion is there, it is advisable that the mother wears mask while breastfeeding.
I think that is
Dr.
extremely important.
Anita, I just want to add two more things. Treat the patient as it is tubercular patient, and also well ventilated space is also needed
True.
while there is feeding.
And
Well,
INH prophylaxis to baby, as madam has
That
already
she
told.
has already covered.
I didn't get that point about that you have to delay the vaccination.
Ma'am, can I comment here?
Vaccination is given after INH prophylaxis is being given of
I
6
get it.
weeks.
I get it. I didn't understand what Uma ma'am was saying. Yes, Pradnya, you were saying something.
Ma'am, the American Academy and all the international organizations where the TB prevalence is not so much, they advise delaying. But our Indian Academy actually it gives because there is
It can.
resistant form of the BCG. So though we don't have it, it is recommended that you immunize the baby along with the INH prophylaxis.
This could be a point of debate for us here. I think let us just
Yeah, even I was having this doubt as
clarify.
Charu had,
We will
because
clarify
we
this
have
point,
never
and
heard of that. Yeah,
we shall put
BCG
it
is
on
not.
we shall put it
Yeah.
on the once we
Charu, we don't have INH resistant BCG, so it's prudent to give it after the INH prophylaxis.
Thank you for that information, ma'am. Yeah,
Thank you.
it's a good
Yes.
point.
So as it was mentioned that breast milk does not contain Mycobacterium tuberculosis, and hence the risk of TB transmission through breast milk is negligible. And we have a number of studies regarding tuberculosis. Breastfeeding should not be discouraged for women treated with the first line
घंटे बाद आएंगे ना
medicine.
उसके लिए उसको
The
भी correct करेंगे.
first line AKT drugs are
Timing
compatible with breastfeeding, and rifampicin can cause harmless orange discoloration of the milk, nothing more than that.
उसको check कर लेंगे.
Untreated, Dr. Taru, we would untreated active tuberculosis should temporarily withhold breastfeeding. The mother can feed expressed breast milk, and isolation is recommended till the mother is infectious, or if she has multi-drug resistant tuberculosis, or is non-adherent to treatment. Prophylaxis with INH is recommended in the neonates. So yes, should the newborn receive BCG vaccine? The answer is of course yes. We move ahead to our next case, which is a 24-year-old HIV positive mother on ART. She delivers a healthy term baby. Her mother insists she should bottle feed to protect the child. She has a CD4 count of 400, which is a very good count, and she's been taking her medication regularly. How do we proceed now in this particular case? Would we be talking to her antenatally? How will we counsel her? How will we be telling her about exclusive breastfeeding as opposed to top exclusive top feeding is our question. So Divya, you want to take this question?
Yeah, sure. Thank you, Dr. Charu. So we have an HIV positive mother who's already on antiretroviral treatment, and she's delivered a healthy baby. Her CD count is good, so it is good even if she should continue to take her ART, and also she should breastfeed the baby. There is no need for expressed breast feeding, and there is no need to
But
give.
Divya, her mother has read somewhere that there is a small percentage of possibility that the child can get HIV if the HIV positive mother breastfeeds. And she says that there is no need to breastfeed your baby. You might as well give top milk. I don't want to have another patient of tuberculosis of HIV in this particular family.
So she is absolutely, her apprehension is absolutely correct. We have to counsel her. We have to tell her that if by giving breast milk, she will be actually increasing the immunity of the baby. So that
Okay.
is one thing. And in case she still doesn't, and we can also give prophylaxis to the baby.
Right.
ART prophylaxis can be given to the should be given to the baby, and that is how we go ahead and encourage the mother to breastfeed the baby. In case she still has any inhibitions, then expressed breast milk can be given, but it is good to breastfeed because she is on ART.
Yeah. So anybody else has any other thought process?
Yeah, there should be clear instruction that
Hmm.
there should not be any mixed feeding. So
Sorry?
if there should be no mixed feeding. That is very, very clear. If she is giving breastfeeding, the baby should be only breastfed. And if she opts for bottle feed or supplementation, baby feed, formula feeding, then she has to.
Yeah. Ma'am, can I comment here? So,
But the sustainability
It is
is
Dr.
very
Anita. Why?
important. Suppose she belongs to a poor socioeconomic status, and she says that after some time she will not do that again. Because it happens that when that mild small erosions are created in the GI tract, and that becomes a nidus and then an entry point for the HIV virus to get into the baby circulation. So that is why mixed feeding is never advisable. Either she has to opt for breastfeeding, that has to be exclusive, not mixed feeding, or she has to go for formula feed, as they have already discussed. So this counseling starts right at the time of antenatal care. So we must counsel these mothers regarding that.
Yeah, so there is so much of disparity between thought process. Sharon, in the US, how do you all go about it? Is Sharon here?
In the US, it's exclusively top feeding. They
Correct.
discourage breastfeeding.
Correct.
And in
True.
India,
Yes.
Yeah,
Actually,
Sharon.
it's just about to change. So, the American Academy of Pediatrics just changed their guidelines. So, for treated patients with a low CD4 count, they can now breastfeed. And our American College of OBGYN is actually working on our statement for a change in policy right now.
Interesting.
Good ART is now available. I have got many patients who are on ART, and their virus count is negligible. So of course she can very well feed her baby now, because her
Yeah.
viral CD4 count is good.
Yeah.
You told this patient has 400. Her CD count is good, and viral markers if done. If the virus is less than 1,000, we are allowing vaginal delivery. So she can very well breastfeed also if the virus is negligible or very low in the
All right. So,
blood.
like up till now, the thought process was that we need to counsel the patient well. We need to let her and her family know the benefits of breast milk and breastfeeding. Of course, she also needs to know that there is a very tiny risk of transmission of HIV through breast milk, and it could be her personal choice that she wants to have exclusive formula feeding, which probably until now in the US it was a norm. But in our country, we all are very sure that the advantages of breastfeeding far outweigh the small risk of the transmission of the HIV virus, and the various immunological and the so many advantages of breast milk will be passed on to the baby, and the baby is going to do much more, much better with breastfeeding. So breastfeeding does carry a risk of transmission, but with optimal adherence to ART and a suppressed maternal viral load, breastfeeding can be given to babies with HIV positive mothers. Now, I think this is again going to be a point of debate. Our panel today is going to be a point of maximum debate because current evidence suggests that in continued presence of maternal ART, mixed feeding is also rendered safe and may be preferred over no breastfeeding at all. So,
Very.
again, a little point of debates out here today. We have a quite a heated discussion with half of our panelists rooting for one answer and the rest rooting for the other. But let us talk to say Uma, Pradnya, and I think Payal. Payal, what is your thought on mixed feeding?
Okay. Yeah, thank you. And a very good evening to all eminent dignitaries. And I'm really honored and humbled to share my experience. So, whatever everyone says, I agree. But in a crisis situation where the mother has not been treated, but she has active HIV and without any medication, and in a crisis situation like earthquake or any war zone or underdeveloped countries, uh, then WHO recommends exclusive breastfeeding over formula feeding because lack of availability of this clean
Correct.
water.
Clean water, right? I agree. I agree with that. But
And
what about
Charu,
mixed feeding? What about the mixed feeding part?
Mixed feeding on in those scenarios we can't trust on mixed feeding because of polluted water and unhygienic situation.
Okay,
So
but if it's just a normal situation, and that she breastfeeds for a little benefit of the breast milk, and she gives a little bit of top milk to prevent the HIV virus reaching her baby, is that an allowed procedure?
so
No, I
here
think IAP doesn't still, recommend mixed feeding. So we should stick to that. Maybe the doctor has already told because of unhygienic preparation of top feed. That may be another factor which adds on to my own perspective to this.
Mm-hmm.
So if the viral marker is negligible or something like that, she can very well breastfeed. So
Hmm.
still, this is not clear about mixed feeding.
I think so. So I think
Yeah.
we draw a conclusion that yes, all HIV positive mothers who are on treatment can and should breastfeed because the benefits of breastfeeding far outweigh the risk of transmission of the virus.
and Dr. Charu,
Yes,
uh,
please.
the biggest study was done in BJ Medical College about
Okay.
giving 6 weeks of nevirapine to all the breastfeeding babies, which will
Okay.
literally make the transmission negligible.
Wonderful. I think that is another wonderful message that, it is my parent institute. The study has been conducted there, and this is such a great conclusion that has been drawn out of it that we are going to promote breastfeeding in all our HIV positive mothers also.
And
Ma'am,
baby has to be in follow up.
there
So
is a
there is a fixed protocol which has been given by IAP for HIV positive mother who have delivered the neonatal screening and the infant screening. There are clear guidelines and we must stick to them. So there are clear guidelines when HIV is to be repeated and when how to follow up these infants. We have to follow those guidelines.
Yes, well taken. Point well taken.
Ma'am, one thing is that when we give the neonatal profile access, it is important to understand whether the neonate is in the low risk or the high risk. Because if it is low risk, we give a single drug profile access with nevirapine. And if it is a high risk, then we use nevirapine and zero-vidine.
Double.
Yes,
Clear.
double prophylaxis. Absolutely. I agree with you on that point, Pradnya.
And
Definitely.
with the introduction of dolutegravir as the third, we have replaced from TLE to TLD. The transmission is just 2% if the mother is on a triple drug ART. So the transmission rate is much less. However, recent evidence has said that rather than giving, so mixed feeding is not unless the AFAS criteria is fulfilled. You should not give replacement feeding, which is affordable, feasible, acceptable, sustainable, and safe. So, in case mother opts for replacement feeding, it should not deter her from doing any, because recent evidence has shown that with the triple drug new regimen, the transmission rate is still less, and ART does take care of the mixed feeding also. So we should not completely discourage. However, we should encourage her to stick to something for the exclusive 6 months, because after that, eventually you're going to continue breastfeeding and add complementary feedings. So
Fine.
mixed is going to be there
Yes,
later.
point well taken. And now we move on to breastfeeding after a C-section.
So I think
Taru?
the mixed feeding is totally it mixed feeding totally not done. I think it should not be. If that low risk patient on ART, then if she is doing exclusive breastfeeding, it's okay. If she's doing replacement feeding and she wants to breastfeed, I think it should be done.
Yes, I agree with you. So we move on to Dr. Taru for breastfeeding after a C-section. Taru, with the rising rates of C-section, what is your experience? What is your personal experience about the golden hour after for breastfeeding after a C-section? About the exclusivity of breastfeeding after a C-section?
Actually, it all depends on counseling. If you counsel the patient properly, that the breast milk is so important for the baby that all the everything immunity is being given, and the mother milk is a gold for those people, those children. Then they understand even in the pain, because the post-operative period, immediately to that golden hour, the patient is under pain relievers. So very well they can give, they can feed their children, and whatever position is comfortable to them, they can
Right.
opt for that. They can, if it is she is able to take lateral position, then baby can be fed in that, or even on the chest wall in baby upright down position, baby can be fed. And we have to counsel all the family members also, so that they support this ki baby has to be fed in that golden hour.
Yes,
It
I
is
agree.
not
But
difficult.
I think, we all are very aware. We all want our patients to breastfeed immediately. But it has been seen in most studies that a C-section can delay the start of breastfeeding and shorten the
That
duration of
maybe
exclusive breastfeeding.
because in primary cases, the breast milk is not properly immediately delivered. In few patients, antenatal counseling was done and they start massaging nipples, and we have immediately, we have after delivery milk production. But most of the primaries, milk production is delayed because of anyhow they are not mm, uh, sitting properly or holding babies, because that is also, latching babies is also very important to have in initiation of the milk production.
To what Dr. Taru has said, I would like to add my own personal experience. We are doing a lot many vaginal deliveries as well as cesarean sections. Now, what happens is the paramedic staff is also in the operation theater is not willing to put the baby onto the breast. They have a sheet, a partition sheet between the anesthetist and the mother's face and the suturing area, the abdomen. So which falls on the chest invariably. We can't put the baby immediately onto the chest. There are so many.
Golden hour doesn't mean only 10 minutes. Yeah. After half an hour
But
also you can.
absolutely agree to that. But if
Golden
you want
hour
to put the
is an
baby
hour.
right there,
It's not
I mean,
10
then there are
minutes. It's an
certain.
hour.
Yeah, and then there are certain hospitals which actually teach the paramedic staff. So even if you've given the baby to the pediatrician, he's seen the baby, and then they put the baby on a football hold position, and there and there inside the operation theater, they breastfeed the baby. So it all depends on how we've counseled the paramedic staff also, and everybody should be on the same page.
Correct.
So what we used to do, Divya, in our hospital one, ours is a public hospital. So one sister from labor room accompanies the patient to receive the baby. So she is now the whole soul in charge of the baby once the baby is put on the mother's abdomen, if convenient, at the time of cesarean. And it is her duty to assist pediatrician in taking care of immediate care of the baby. And what she does is, once she puts the baby on the breast of the mother. So because Delhi government is very,
Dr.
very
Anita, this is
particular.
what
Yes,
Divya was
yes.
saying. We have to we have to teach paramedic also. Until unless we teach
So
them,
yeah,
they
you
will
have to
do.
make hospital protocols. Not only teaching, you just make it a this thing that someone will accompany her, either her own. Means, of course, if you allow birth companions in OT, nothing like that. But if you are not allowing, like we are not allowing inside maternity OT, our sister goes from labor room and she helps a lot in initiation within half an hour. So we are very, very
That is a
particular
very, very
in here.
positive thing that there is a kind of a one-on-one ratio as far as a
Yes.
patient and a paramedical staff is there for breastfeeding. But I mean, you are really fortunate in your public hospital, but in any private hospital, that is not the case. And it has been
True.
seen that women who are delivered by planned C-sections have no intention to breastfeed. And they were found to have a higher proportion of breastfeeding difficulties, and they tend to discontinue breastfeeding before 12 weeks. So I think counseling, and only counseling
Yes.
is extremely important for all this. And I think that some changes can be made in the kind of IV fluids that we give, and the proactive lactation support that we give to these particular patients, as you were rightly saying. And I think there's one more slide over here. The enhanced recovery after surgery protocol. This is rather important, where
Right.
early oral intake, early mobilization should be followed to establish the breastfeeding goals post C-section. Adequate analgesia post C-section ensures a comfortable breastfeeding experience, and the football hold or the side-to-side lying holds are the positions that have been strongly recommended. And I think that this is a very, very, very important, special situation considering the rising rates. And I think, even our girls tend to get a little pampered, that, the family saying, "Arey, she's just had a
Yes.
C-section. How can she breastfeed?" And you see that the baby's in the lap of the mother-in-law, and or the mother, and they are the senior members of the family are looking after the baby, just because they are pampering the girl that she's had a C-section. Let us not trouble her and let us not disturb her. This point has to, be changed. So
And also, Charu, many
yes,
times we should try to restrict, as you said, the IV fluids because it causes a lot of nipple edema, areolar edema, and the
correct.
baby cannot latch.
Absolutely. I think that is a very good point, because the areolar edema is a very, what do you say, routinely seen problem, and that can cause a lot of feeding problems. So that is one point well taken, Dr. Ma. And okay, coming to our next case of double trouble. You have a 29-year-old primary who delivers preterm twins at 34 weeks. And the mother is in a private nursing home, and her babies have been shifted to tertiary care, NICU. So, Nibha, uh,
Yes.
you may be coming across such situations. And how do you think that we should be going ahead in these kind of cases as far as breastfeeding is concerned?
Yes, it's a really double trouble. Even the preterm and the two babies.
Correct.
Two babies to a mother itself is a problem, and preterm, like it's 34 weeks. So I think suckling must be good.
Correct.
So there must not be problem in breastfeeding or giving them the express breast milk. Otherwise, if it had been earlier, then it had been problem if they have been suckling problem and
Right.
more. So
Right.
for these babies, I think expressed breast milk initially we can start if they are not suckling properly.
Right.
That would be good. And babies should be close to mother, so that the warmth, the emotion, the confidence is there.
Yes.
And breastfeeding should be initiated as early as possible. And there are two babies, so different positions should be explained to mother, so
All
that she can feed both the babies. And if she's having problem, then I think with twin there should always be family support. The staff support should be strong for the emotional support, and otherwise also looking after mother apart from the breastfeeding, so that she does not lose her confidence about this, because she has to look after the two babies. So in that way, and then if they are low birth weight, then mother can do kangaroo breastfeeding also. Kangaroo
I
breast
think
can, that will be
that's a very,
really
very,
wonderful.
very comprehensive answer you gave, Nibha. I would like to ask Dr. Payal also as to what is her experience with preterm babies and breastfeeding.
I'm very happy to share. We recently had a preterm baby. I mean, the babies will be 7 months, just, the day after tomorrow.
Mm-hmm.
The same situation. And I'm very happy to share that, babies were gaining 40 grams per day. With
Wow. Okay.
Huh. So, if we can counsel, the most important thing is, counseling not only the mother, father. Father plays a very important role. Father's encouragement, the way the father helps the mother, it is very crucial during pregnancy and after delivery.
Right.
So
Right.
if you can, empower the father, automatically we can make sure that mother will feed the baby well, and father will take care of the rest of the other things.
Absolutely. I think very well said. It is indeed a difficult situation. We are all very aware that looking after one baby is so difficult. Twins are definitely going to be quite a handful, and that would when they are preterm. Any special devices that we want to use for feeding these babies? Do you think that what teaspoon feeding or palladi feeding will be required, or they will be able to latch on? Anybody can.
Calf feeding actually helps. Calf feeding, or if the baby is unable to latch, we encourage finger feeding
Okay.
so that the suckling
Correct.
improves. And slowly and gradually putting the baby more skin to skin contact,
Yes,
and
yes,
the baby will be completely on breastfeeding.
absolutely. We would want a little bit more about the kangaroo mother care or the kangaroo care, no longer kangaroo mother, but this thing. I think that Divya, you want to take up a little bit about the kangaroo mother care?
Yeah, kangaroo mother care is a fantastic.
Voice is not coming.
Hello, can you hear me?
Yes, yes.
Yes.
So kangaroo mother care is very good. It actually betters the mother-child bonding, number one. It maintains the baby's temperature. She needs less of the incubators. The baby needs less of the incubators. And also it encourages frequent breastfeeding. It also, it propagates breastfeeding. So there are so many advantages to kangaroo mother care. And when we see it happening practically, it's very, very feasible and practically possible. Otherwise, one tends to think, how can that be done? So we have even twins with, the mother and the father sharing the twins and doing kangaroo mother care.
Yes.
So this is really very important and good.
I had the opportunity to do a podcast with Dr. Prashant Gangal, who is a what do you say, very doyen in the field of breastfeeding, and he always talks about the mother monkey. And here we talk about a kangaroo, but when you talk about the mother monkey, he says that uh, how does the mother monkey and the baby monkey be? So the baby monkey is always clinging to the mother's abdomen, whether she's moving from one tree to another tree, whether she's gathering food for herself, whether she's sleeping, but that skin to skin contact or the baby being able to suckle as and when the baby wants to, okay, that goes such a long way in looking after the baby's health, developing the bond between the mother and child, that this skin to skin contact and this kangaroo mother like care, we no longer call it mother because the father or anybody else from the family can give this
Yes.
kind of care, but that will go a long way in looking after the baby and making sure that the babies do well even if they are preterm babies. So that was a very good
More
discussion.
so relevant in preterm babies because we know that fat is less in them.
Yeah,
Food
yes,
temperature regulation is an issue, so it
abs-
can be given by anyone. It can be father, it can be
abs-
grandma or a grandpa. Anyone can give.
absolutely rightly said. Absolutely rightly
And
said.
once started, it should not be changed very frequently, person to person. Like one person is doing, it should be continued for 6 hours.
Right. So we had a great talk by Sharon on working mothers and why they abandon breast feeding. One of the most important things is the aggressive marketing of the breast milk substitutes and the feeding devices, and of course, lack of support. And we have to look at ways to overcome it by planning ahead prenatally itself. Excess milk can be stored as per guidelines, and work from home is a very, very good option, which at least our IT professional can look into, and part-time options should also be explored by working mothers. But I think that Taru can just guide us a little bit about the art of breastfeeding, of what do you say, breast milk expression, how it needs to be stored, and how her family can help with this feeding of the stored milk.
Actually, there is a rule of three. Very
Yes,
important. Everyone should know. The
yes,
three, if there's a fresh milk, we are keeping outside only at room temperature. It's for 3 hours only.
correct.
If we are keeping in fridge, refrigerator, then it is 3 days. But if we are deep freezing, then we can keep for 3 months.
Absolutely.
So
Very well
this
said.
is very important how we can express our milk and store. Because for working females and going for work, it is important. And those who are having excessive milk at times,
Yes.
they can also store and keep the milk.
And
At
there is this
times,
thought
maybe
that,
sleeping for a longer time.
yes,
And when they get up, they're more hungry than the
rightly
production of
said,
milk.
rightly said, Taru. And there is this thought that there are some women who produce colostrum antenatally itself. So if it is easily flowing, it has been suggested that they store this colostrum in 2 cc syringes and put it in the refrigerator after or rather the freezer after labeling
Then
it.
this is a nice idea.
That can be used in the initial days when the milk production may or may not be adequate for the particular baby.
Yeah,
And
we'll have a
And
of
there
it.
is a thing called insurance pumping, in which the mother knows that she's going to go for work, say after 6 weeks or 3 months. So
That's
what
a
she
different
does
thing.
is in those
This is the
6 weeks,
colostrum
Wholesome
antenatally
harvesting.
when patient
yes,
is
yeah. So
It's the
what she does is in those postpartum 6 weeks or 3 months, which she has with the baby, during that time, she starts storing her extra milk in the freezer.
abs-
So, and also, like suppose she has to go in for work in the morning. So in the evening, she comes and she can store her breast milk and, at least 2 to 3 times. And then the persons at home, they can provide that milk to the baby.
absolutely, absolutely.
So that
so
way.
instead of every time keeping and giving fresh milk, they can replace a previous milk to use earlier. Then they
That is
can
right.
use an fresh milk later on because maybe later on she's not expressing so much of milk.
Right. So probably because of lack of time, we will just have a little bit of rapid fire like questions. Taru, this lady has a left breast abscess. She's a primey who underwent a C-section. And she has 3 questions for you. Firstly, why did it occur? How will you treat it? And can she continue to breastfeed her baby? So
See,
that's one line answer.
this is a staph infection. It
Yes,
occurs when there are cracked nipples or the baby is not latching properly or inadequately mastitis is not treated in time. So they land up in breast abscess. So,
absolutely. How will
so
you treat it?
the abscess is treated only by antibiotic and the IND.
Oh,
IND can be done by
avoided.
these days we are not doing IND completely. We are taking out by syringe.
aspiration. That's
Directly
right.
under local anesthesia, we try to
That's right.
take as much as pass outside so that doesn't make a big wound and
Correct.
they are able to express milk and feed babies also.
So can she continue to breastfeed the baby?
If the abscess is not that much, It is approaching nipple and is not able to feed that way. And she has to continue feeding baby. And if it is in both the breast, it is very difficult. Then they have to express milk and feed the baby.
Yeah, so but breastfeeding is definitely going to continue. But Uma, in your opinion, what do you find when women get breast abscesses? Their psyche gets totally deranged, and
Yeah, they feel that the breast milk will contain the pus. Actually, the breast, it is the stroma which is infected.
That they have
But
got pus
many
in the
times
breast.
the baby itself doesn't like the taste of the milk
taste
in abscess.
that can
And so, if the baby is not drinking, it is recommended to express milk so that the milk flow continues till she is healed, and then restart.
I
There is a smell also, and that is why also baby doesn't want to feed
Yes,
directly.
from other breast.
She can feed, of course. She can feed even in this breast, but many times the baby doesn't feed.
yes.
To express, continue to express so that
Pragya?
milk flow is
Yes.
continued.
Mothers with breast cancer on chemotherapy to breastfeed or not to breastfeed?
Not to
Not to
breastfeed,
breastfeed.
chemotherapy.
So
Payal?
there are certain chemotherapeutic
Yes,
drugs
but very,
which
very
are
few
given
of them.
to
That's right. Payal,
But
refugee
we
mothers
must be sure, like alkylating agents on and all these, they are contraindicated. So we must be double sure before allowing them for breastfeeding.
correct. Refugee mothers in war zones, Payal?
Very much recommended for breastfeeding.
That's right. Narcotic addiction mothers.
Yeah, that is a question.
the
Mother
mothers
should
who
be counseled not to use narcotics while she's breastfeeding. But if she is dependent, then it becomes a challenging situation
Cannot,
because,
if they're not
of
on,
course,
Not
we
to
need.
breastfeed because it contains sedation.
Yes, yes.
if they're not on the methadone recovery therapy, rehab therapy, they cannot.
They
Active
cannot.
chickenpox 2 days before delivery.
So it is
So,
better
Express milk and give.
not to feed
and
because
not to
antibodies
feed.
are not formed still.
Hmm.
So
So the
And
baby
if the
must be
lesions are around
varicella
nipple and
immunoglobulin. Sorry,
yeah, and it will
varicella
be difficult.
immunoglobulins to be given to the baby, and the mother should be put on acyclovir or any antiviral therapy, and then keeping isolating the baby, rooming apart both and then express breast milk can be given, maintaining all the hygiene.
We can give expressed milk.
Yeah, probably we can give, but I think breastfeeding
You have
is
to keep
relatively
available.
contraindicated in this active chickenpox 2 days
Yes,
before.
yes.
yeah,
Whereas follow, they say that better avoid. Yes,
Yes. Mothers on IV antibiotics.
Absolutely
can
given
be
breastfeeding.
given. We
We
can
can
be given.
We
I
can
think
give.
an important message over here would be that you feed the baby and then after that give the IV antibiotic
correct.
so that the concentration of the antibiotic in the milk will be very, very
Yes,
negligible prior to the next dose. So that's how it is. So I think HbSAg positive mothers,
can be given.
Breastfeed.
100%, 100%. And with that, we welcome you
We
all.
have to give immunoglobulins to the babies.
Yes, yes.
HbSAg.
Welcome you all for the BreastCon 360, which is a fantastic conference on breast health and lactation on 23rd and 24th of August in the beautiful surroundings of Lonavala. We look forward to meeting all of you over there. And before we wind up, we would want one take-home message from each and every panelist. We can start from Payal.
I just want to say that not only the mother who delivered their baby, even the commissioned mother can breastfeed.
Yes,
And
of course.
we have
yes.
many mothers who got their babies through surrogacy,
Right.
and they feed their babies right from first hour after delivery till 2.5 years.
Wonderful, wonderful, wonderful. Absolutely well said and absolutely rightly said. Pradnya?
And can I share, Dr. Charu, if you allow me just 10 seconds thing.
Yes,
Uh,
of course.
okay, there is a proverb that African babies, they don't cry, and
Acha?
because in pygmy tribe, the father, if the mother goes out after delivery for hunting or any other thing, father puts the baby onto the breast. That is known as chest feeding, and this is so breast. This tell us that breastfeeding is not only about food; it's about the comfort, love, security, and everything.
Wonderful. I think that's a very
All right.
important take-home
And
message.
80% of the time, research proved that those babies will be on somebody's lap, not alone.
Right, right.
And that is the reason they cry very less compared to European or Asian babies.
Oh my.
Thank you.
Okay.
So one more thing,
Yes,
we have discussed great panel on breastfeeding. We should not undermine the importance of milk banks also. So mothers who can donate, please donate for those needy babies who are unfortunate, who cannot get breast milk of their mothers. So please, many cosmopolitan cities are now having milk banks. So we must think about that aspect also, because it's a great service to humanity. Thank you. Thank you so much, Charu, for giving us opportunity.
well said, Anita. Well said.
Okay, thank you, Dr. Charu.
Yes.
Madam, I think
Please tell me your message, Taru.
My message has been given by Dr. Anita. I also want to say this. There should be more and more milk banks because there is a scarcity and few milk banks are out there, but they're insufficient for their own newborns are demanding them. They are not giving to others in private. So we have to increase the number of milk banking in private.
So, Dr. Charu, after the panel, I think we've realized there is hardly any condition in which breastfeeding cannot be propagated or encouraged. So, since we've learned that, we have to counsel our patients, implement whatever we've learned. So, the practical application is very important. This is my message. Spread the message of breastfeeding.
Well said. Well said, Divya.
Antenatal counseling, antenatal and intranatal counseling for breastfeeding is must, and we must get them mentally prepared that the breastfeeding, earlier breastfeeding and exclusive breastfeeding is beneficial for both the mother. That if they are mentally prepared, they will do. Otherwise, it's delayed and they are hesitant about this even after cesarean section.
I think after the pious message, I feel we'll start thinking on this. My baby can be given to father.
So, Dr. Sonia
Yes,
wants to say
absolutely.
something.
That's right on your part.
if I could just add on, madam.
Yes, of course.
Just add on the wonderful panel. And madam, I feel the best thing what we could do initial to start with is the antenatal period counseling of breastfeeding, both to the patient and the family attendants who are along with her for an antenatal checkup. That is the time they can have some thought process and something what we speak is really imbibed. And that is the time when the waiting period in the antenatal visits, we can have some video presentations when exactly how breastfeeding has to be initiated, the kangaroo care, how is to be initiated. So they are in a very calm and composed state where they can accept the facts and they religiously follow. When we are too much worried about PPH, where the uterus is contracted, something is happening, because last week this happened. So every month when the patient used to come for antenatal checkup, she was always seeing these videos and talking to the delivered mothers and all that. So after the delivery, yes, there was atonic PPH. The team was very much worried doing this, but she was very composed and said, let the team keep doing. Please give me the baby. I will start breastfeeding. This is what I have learned from the antenatal visits, what I've seen.
Wonderful.
So, when we are totally into our obstetric picture there to save the mother for due reasons,
yes,
the mother is knowing what to do herself. And that I think we can use that time period where they come for antenatal visits and in the waiting lounge.
Exactly. Very true.
Second, I think mastitis, always nipple shield, just to make her connect with, not to wean off completely. Breast nipple shield will definitely help. So what we need to make them understand is feed. Feed is the breastfeeding. Feed, F-E-E-D. F is feed on demand. Whenever the baby demands, just feed on demand. E is educate, not only herself, the entire family. E again is to express milk whenever needed. And D, important, is diet of the mother.
Well said.
So I think with this note, the wonderful panel with wonderful questionnaire and
We had a
moderating
good panel. It was
experts
very
and
interesting.
And
opinion.
Charu, one more
Hema,
thing is that the
yes.
pediatrician also, they should be refrained from giving one or two formula foods feeds, you
Arre,
know.
they are
I
the
know.
ones
They
very
are, yeah.
Yes,
important.
Yes,
So
yes.
what
yes,
happens is,
very
I think this is a little informal discussion going on now, is that they say, oh my God, the baby has lost 300 grams in the last 10
Yeah,
days.
Yes.
And, the baby is so cranky and the mother is, I mean, there's hardly any milk or whatever. I don't know. And then by the time the baby comes to you,
yes.
the mother comes to you for follow-up after 8 days, the mother is more than 80% formula feeding.
correct.
And you don't know how to go back now. You just don't
And
know how to
added
go
on,
back.
there will be physiological jaundice also happening, ma'am.
Yes, and they say
Yes,
that the jaundice is exaggerated because the mother is not feeling
yes, yes. It
well.
happened recently with me also.
It is such a
The
difficult. You
pediatrician
can't.
admitting the baby, saying
Yes,
that the baby did not get proper milk, and that's why hypoglycemia, that's why jaundice, and admitted the baby for 48 hours
so I
and
think our next webinar should
things like
have
that.
the pediatricians
So
also talk with
Exactly.
us.
I know,
Yes,
exactly. We
yes,
should bring our pediatrician and we together. The pair
correct.
should be there.
Yes,
So yeah, Payal is setting up a milk bank for rural
yes,
babies of
yes.
Karnataka. So congratulations on that.
We
Yes,
also are coining in our city, ma'am. The Rotary is trying to channelize this. I'll take some inputs from Dr. Payal
Very
also.
good.
yes,
Very good.
yes. So I think we come to an end of this wonderful webinar, and I would request Dr. Sonia to do the honors of.
Thank you, Charu. Thank you from all of us.
Yes,
Thank
yes.
you, Divya. And thank
Thank
you,
you,
Safar,
Dr.
for this
Charu.
opportunity.
Thank
Thank you,
Ma'am,
Dr. Charu, as
you.
your
Charu, ma'am.
charming moderation and your questions, they're always so helpful and always welcoming. So please continue to be, be a very active part of the breast committee.
Right.
Always.
I sure hope to be
Very
so.
right.
so
And
formally, we can end this insightful, enriching webinar. It's
yes,
my privilege to deliver vote of thanks. Of course, this is under the umbrella of SAFOG, and I thank President of SAFOG, Dr. Shyam Desai, and Secretary General SAFOG, Farhana ma'am, who's made possible. And we should definitely thank in chorus, Dr. Hema Divakar, whose visionary guidance has continually supported us, and she's been the cornerstone of today's session, along with Dr. Charulata. I was just making points when Dr. Divya, co-moderator, the co-convener, was also mentioning now that Dr. Charulata, thank you, very charming. So I was just thinking in my mind, oh, C for Charulata and C for charming, and coin along with Dr. Payal's message. Yes, we understand it is colostrum harvesting, again from C, and again C, which is chest feeding, which we actually learned today, and all C's together, charismatic. The closing remarks is just too much of take-home messages for the audience here. I thank each and everybody who's logged in today, and special thanks to our speaker, Dr. Sharon, and wonderful panelists, all of the panelists who are on screen. We all know you as the visionaries of Foxy for tomorrow. So doing good work and coping up with all the stress levels and being a wonderful obstetrician, but taking all these messages to onto the desk, and also for our nursing staff and paramedics, whatever we have learned today and exchanged today, will reach out to our team in our own centers, is what this webinar is made to happen. With this note, I think we all know that the kangaroo care, what was coined, was originated in Colombia in late 1970s, which reported because of the critical shortage of incubators. From 1970s, now 2025 made it possible. And now we know that Dr. Charulata is making all of us run for breast health. With this, we'll all join you, ma'am, and all the very best for your next August 23rd, 24th conference, and at the next conference, what you said, run for breast health. Thank you very much. And not to miss Saiti, she was wonderful coordinating from the day one we thought of having this program on the 5th of August 2025, celebrating knowing much about breast health, breast milk, and whatever possible in this particular week, and celebrating Breastfeeding Week. Thank you very much, one and all. Special thanks to Madam Dr. Divya, guiding me through and through to convene this particular webinar. Thank you, Madam.
Thank you, Dr. Sonia. No less charismatic, and we've really had a wonderful time. Thank you once again, Dr. Charu, and thank you, Dr. Hema Divakar. We can't
To
thank
all of you, my pillars of strength and support, the breast